Let me see what I can do to try to follow up on Seth's presentation. It's always hard going second, and so I sort of thought about this lecture after Seth's presentation, and both of us didn't have a chance to really coordinate what we were going to say. And so I thought about this more as the good, the bad, and the ugly. And the good part is that Seth actually gave a wonderful broad overview, which I would have expected that he would have, from probably the 40,000 foot perspective, and gave some good insights. And the bad part was that I had to rewrite my talk last night, and so I spent a lot of time redoing things, and I thought about it from the perspective of actually hearing some of the information that was presented from our colleagues at the Methodology Center, and trying to bring it down to some of the lessons learned from the field. So bringing it more pragmatic in terms of things that we've learned from some of the development and the evaluation of some of the biomedical interventions that we have. And no presentation about HIV prevention would go without putting up the requisite CDC slide and essentially where the epidemic is, and the fact that really for the last 10 or 15 years we have not made any real dent in a new HIV transmission over that period of time. And so we still have a lot of work to do. And certainly some have attributed this to the fact that we have literally 75% of our population who is virologically not suppressed, and that has been part of, and we heard yesterday, the rationale for moving more towards a treatment as a prevention approach, with many of the limitations that Seth put forward yesterday. And so in terms of deviating slightly from that, I thought maybe that what might be useful, given what we heard yesterday, is to really focus a little bit on some of the health disparity issues, specifically among MSM and women. We didn't hear much about the criminal justice involved populations, and so I thought maybe perhaps I would throw in a little bit of that. I will leave the adolescents work to those who are skilled and have more expertise on that. Talk a little bit about some of the social comorbidities, and then to focus a little bit more on some of the other medical and psychiatric comorbidities, such as substance use disorders, really disentangling some of the issues around alcohol and drug use and mental illness. And I will just say parenthetically that it is often the case that I hear researchers talking about those as social issues, but they are indeed DSM-4 criteria. They can be treated. There are effective evidence-based interventions. And I will try to make the argument in this that part of treatment and prevention for HIV is effective treatment and prevention of the underlying substance use disorders. Now, none of this work can be done in sort of the single isolation of these interventions, and part of what we have been hearing about are some of the components of the core elements of these interventions and how to perhaps disentangle that. And then I think today we're going to hear a little bit more about SMART and these sort of adaptive methodologies to study things. But I also just want to make sure that we're very clear that most of the things that have been talked about are really those things that are focusing, on the individual. And you can use whichever model that you want to focus, whether it's IMB or the health behavior model. I mean, there's a ton of them out there that really focus specifically on the individual, but to also say that some of the interventions and the activities that are really created and are evidence-based are those that involved relationships as well, such as couples-based therapies, and that's part of what HPTN actually does, some of the social network information, how family and social networks come together, trust between providers and patients, as well as those factors that go on more broadly at the community level, such as stigma, poverty, going in and out of prisons, and how our health systems are organized with regard to either siloed care or integrated care, what sorts of reminders that we have built into our systems in the community and the extent to which they are integrated and not integrated, and then certainly at the greatest macro level, and Judy was alluding to some of these yesterday, are some of the sort of guidelines that actually change as we're embarking on our studies. such as partway through some of the studies, if one is doing a strategy for improving the behavioral of HIV testing, having a change in guidelines, the way that siloed funding sources may intervene. I think we have an incredible opportunity to think about how our interventions will fold into the Affordable Care Act and whether or not Ryan White will be a thing of the future or not. And as we think about these sort of combined biomedical interventions, do they have the potential, if they are combined intervention, to have sort of this aggregate benefit? That is, that these quality health indicators that cross many domains, whether it's prevention and treatment simultaneously, if we can think more creatively about how we can use some of those things to more comprehensively think about the way that we analyze some of our data, and then also some of our policies around incarceration as they change over time and disrupt people's lives. Now, I will say one thing, the website thing looks very good, and I will ask Aaron to be very kind to me with the photograph. I would like black curly hair and my wrinkles to disappear by tomorrow. So, anyway, in going to the sort of HIV treatment continuum and looking at the first step with the idea that it's a biomedical intervention, that people actually have to get tested. We know that in 2006, the CDC recommended that we should move more against risk, move away from risk-based testing, more to routine opt-out testing in a number of different venues and for certain groups, that we would remove the issues around separate consent, and states have peeled away many of those sorts of requirements. That pre-test counseling is not required, although for positives, post-test counseling is beneficial. And then the question that I will sort of put forward as we begin to think about where the epidemic is among transmission is repeated testing. How often and for whom? So let me just say that there are a number of community randomized trials that are out there, and I won't spend a lot of time on this, but these are the sorts of things that actually would be sort of somewhat amenable to the most strategy with regard to combining things such as HIV counseling and testing, in some cases circumcision, some cases not, and various levels of intervening with antiretroviral therapy depending upon where the studies are done. Now, have you noticed that over on the far right-hand side with HPTN 065, there was only one of those that is done in the US, the rest of them are done in sub-Saharan Africa, and you can see that the CD4 count criteria for initiating therapy is different. In some cases it's for all HIV-infected patients, and in some at the sort of the WHO criteria that was just recently changed to greater than 500, and looking at the sort of community levels of incidence and outcome. And so the question will be is which part of that package of interventions is going to ultimately lead to an outcome. Now, as we look at the cascade, and we can sort of agree or disagree on the extent to which people know that they are diagnosed, but in general, people sort of suggest that there's about 20% of people who don't know that they have HIV, leaving 80% who are diagnosed with HIV. But a number of studies, and there are some differences depending upon geographic region in the world, but in the US suggest that about just under half of those new infections come from individuals who are already known to be positive. And so that sort of treatment as prevention sort of paradigm is targeted towards 50% or so of the new infections. But the question is that among those individuals who don't know their infection, is there an opportunity to potentially intervene at an earlier point? And let me just make the argument that among those, much of the infections are occurring with acute HIV infection. And this just gives you a diagram of the earliest phase, because most of the existing strategies for testing someone with HIV are not going to identify an individual who is in the acute throes of HIV infection. And in fact, primary or acute HIV infection is associated with a number of symptoms that are not that dissimilar to the flu. Some notable differences are a rash, but it's a very, very light rash. Most people don't even notice it. And if you go go back historically, many patients, 50 to 70% or so, will say, oh yeah, I did have that sort of symptom if they were sort of recently infected. But in general, it feels like the flu, and people sort of pass and go through that. And so the question is there a way to identify those individuals and to intervene at an earlier time point, because that's also a time when viral load in replication is the highest, well into the millions. And in fact, recent data suggests that it's in the 3 to 4 million range and highly variable between 1 and 10 million copies per viral load. And the viral load is really quite predictive of transmissibility. Now, we have a sort of a series of generations of serologic tests for the diagnosis of HIV. The most recent fourth generation includes both the IgG, which is the chronic, the IgM, which is the more recent antibody, and then more earlier on in that course of the infection is the P24 antigen, such that we can begin to start to identify some infections as early as 15 days. The Western blot is oftentimes normal. However, HIV can be diagnosed earlier on with regard to doing some individual or pooled nucleic acid amplification testing. But if you take a look at the guidelines and what you do with these individuals who have acute HIV infection, if a person has reported symptoms and risk behavior, and if you suspect, that is, if the person actually gets into clinical attention, that they may have an acute retroviral syndrome, and their HIV serology is negative, but their viral load is positive, then you would actually go on to do that. I should say their antibody is negative. You might do the viral load in that setting to diagnose acute HIV. And then for those patients who have acute HIV, it's recommended that you actually repeat the serologic testing over the next 3 months rather than do something to potentially intervene. And so these are the sorts of places where we can sort of move the pathway earlier to potentially intervene, and we can think about what we might need to do, whether it's sort of risk reduction counseling for those individuals, or potentially use the driver of HIV transmission by using antiretroviral therapy to reduce that down to 0. Now, just recently, in fact, this month, published in the MMWR, the CDC actually has 2 parallel studies. These are information from the 3-city study. And it looked at using this 4th generation test and then doing nucleic acid amplification. And they found data that actually confirmed previous data. They tested them in a number of different venues. And about 55% of the individuals who were diagnosed with HIV had acute HIV infection, according to the existing algorithm criteria. So it is potential that this can be done. The scalability, however, is not known. And so the questions that I think that are going to be raised as we're sort of moving the field along and how we're going to think about what's new and what's hot is how frequent and who should be tested. And if we're going to look at high-risk groups, are we now going back to sort of identification of high-risk groups in order to do the testing when we've moved away from that in doing the routine testing? And should the acute HIV algorithms be expanded so that we can identify these individuals, and that should we just use the sort of routine post-test HIV counseling and testing to reduce the risk in chronically infected with acute HIV infection? We know that just learning of one's diagnosis reduces your risk by as much as 60 or 65%. So there's some benefit that is there. But is there some potential additional benefit above and beyond what is done with routine counseling and testing, and that is the initiation of immediate antiretroviral therapy to reduce HIV transmission? And then, of course, we could talk in a different conference about whether there would be some benefits to the individual over that. I will say parenthetically that NIDA has funded us to do a trial of a randomized controlled trial, and as I heard some of the presentations yesterday and thought about things, it's really quite reminiscent of the HPTN 052 study in that people get immediate versus delayed antiretroviral therapy. We're doing this among MSM in Peru. And then the other sorts of factors are that in terms of coping, all of a sudden one has a new diagnosis and they're going on to antiretroviral therapy, which is not been the traditional paradigm for treatment. So what happens in that setting? Will people go on to therapy? And what needs to be done as part of that counseling? I will say that they're getting the Cadillac rather than the Ford in terms of treatment. Not that Fords are bad. I don't own a car, so I don't know about these things. But the question is that in these epidemics of individuals who are acutely seroconverting, will we also have to simultaneously deal with a number of other underlying problems, and specifically the contribution of alcohol and drug use to risk behaviors that is associated with the HIV transmission? So where this study is being done in Peru, in a sample of over 5,000 MSM that were recruited across the country, with 60% of them being in Lima, where the study is being done, you can see that there is an increased risk, an increased contribution with any alcohol use disorder to 5 of the risk behaviors that are associated with sero-incident infections, also known as the Alaska criteria. And that as the alcohol use disorder increases, so increasing in severity, it increases the risk in an almost linear sort of formation. And in addition to that, 3 out of 5 of these risk behaviors that are associated with incident infection are also independently associated with concomitant drug use. And so how will that impact that sort of an emergent and acute treatment for HIV in the setting of acute HIV infection? So let me also just say that with regard to this same exact setting, in patients who are enrolled in care, this is over 300 patients, and presented at the International AIDS Society just recently, looked at 2 dependent variables, that is optimal adherence, that is adherence greater than 90%, and perfect adherence greater than 100%. And having an underlying alcohol use disorder was the major mitigating factor associated with decreased adherence in this group of HIV-infected patients who were prescribed antiretroviral therapy. So what will be the additional contribution of what kind of intervention in order, if you're going to provide that Cadillac that is going to contribute to the most outcome with reducing HIV transmission? Now, as Seth pointed out, oftentimes adherence and risk behaviors are linked. In fact, I think he showed that first. But there may be situations, not all of the explanation are they in complete parallel, but they're not always linked. And so the question raises is, what should you do for these individuals? Do you need one of these sort of walkie-talkie interventions that do cartwheels and backflips that are comprehensive as a behavioral intervention that also incorporates alcohol and drug use reduction? And as we heard yesterday, in terms of the types of DEBIs that are available for different risk groups and some of the common components, there are actually even fewer for individuals who have underlying substance use disorders. So we heard from Ron yesterday that there's a handful for MSM, even though they're contributing to 60 to 70% of the epidemic, but even fewer for drug users, and they are a smaller amount, but they are individuals who have more problems with regard to associated risk behaviors and transmission. And then, or is it that you can actually control the underlying substance use disorder through effective treatments? And that would be, through, let's say, in the case of alcohol, we have 3 evidence-based treatments that are approved. Naltrexone in its oral formulation or in its extended once-monthly injectable formulation, or acamprosate, which must be administered 3 times a day, and let's just think about the problematic adherence that we'll have with that, or disulfiram, which probably should not be done in any situation other than in directly observed therapy, because patients don't take it when they want to drink. And or do you need a combination of those in order to achieve the most optimal outcome? Now, as we think about other vulnerable populations that may be at increased risk for HIV, let's turn to the criminal justice system, where there are 10 million people who go through annually. It is disproportionate among, that includes people of color, people of lower socioeconomic status, and individuals with underlying substance use disorders and mental illness. In that setting, we know that the HIV prevalence is 4 times greater among prisoners than in the general community, and 1 out of 6 of the 1.1 to 1.2 million people with HIV cycle through a prison or jail each year. So it is an opportunity to, one, either to identify or to re-engage many individuals who are not in care outside of the community. And also, if you think about where you may have an intervention, that 95% of those people have their interaction primarily with the jail. But they're very, very short time periods. You may have a matter of hours to days. And in fact, in some of the nation's busiest jails, let's just think about the magnitude of the therapeutic effort that would have to be done. But if you happen to be in LA County Jail where they process 900 patients per night, and you have a short time to do an intervention, it may be a little bit challenging. So you've got this rapid turnover that you could potentially do some testing. There's also documented that individuals with and without HIV also have high HIV risk behaviors after release. And in 2009, the CDC provided guidance, but it wasn't really quite as strong as it was for the opt-out testing for other individuals. It suggested, as opposed to really said that this was the evidence basis, that opt-out testing should be done if feasible. So there's that caveat, that risk-based testing is fine, as is opt-in testing in that setting. Just subsequent to that, we published a study looking at a randomized controlled trial because, as Seth said yesterday, well, it's one thing to say that there's a proof of concept that you can do that. And the CDC did a very nice 5 big jail study showing that it was actually quite feasible to do that within these jail settings. But the question is where are you going to get the most bang for your buck? And so the sort of challenge has been, and the notion has been, when do you actually test these individuals? If you wait too long, that is, they're calmer, they're more at peace, they haven't just been thrown in off the street, they're not going through the throes of withdrawal, that they're not psychologically distressed, they're already gone. So you've missed them. Or do you do it immediately under these throes and have them being, one, either unable to opt out ethically, or not? And what we found looking at both women's and men's jails, that the most optimal time period is about 24 hours after entry, time for them to kind of get through that intake process, to cool their jets a little bit, to figure out whether or not they're going to make bond, and then they are more likely to get tested. And you have higher rates of acceptance of the HIV test the longer you wait over time, but you also have fewer people who are available for testing in that setting. Now, for those individuals who end up staying in prisons, the good news is, and one would certainly never recommend that incarceration over community-based treatment is the option that should be done, but for a system which is sort of mandating that individuals go into treatment, and I will certainly make the argument that increasing your resources to less expensive community-based treatment is the right way to go. But over the last 10 or 15 years, individuals who do come into prisons and jails have really achieved parity with their counterparts on the outside. And part of that has been sort of rolling out of antiretroviral therapy, a number of class action lawsuits. And so individuals actually do well for the most part, with some notable exceptions depending upon where they are. But there's an entire litany of lawsuits to suggest that it is always less than perfect. Now, what we do know in a sort of a study that was done by Sandy Springer was that individuals reduce their viral load and they increase their CD4 count, as you see in the purple here, during incarceration, but 3 months after release you see a complete reversal of what is going on for these individuals. And Jamie Meyer, who is here, has sort of updated this analysis. These were data when the regimens were 3 times a day, et cetera. And we've done better. Our report card is that we've done better over time with more simplified regimens and the ability to do this. But our report card did not go from an F to an A. It might have gone to a C- at best over that time period. And so the idea is that this period of release from the facility is really fraught with, at the time it was 59% had a non-detectable viral load at the time of release. That's moved up to closer to 80%. After release, you have a threefold reduction with regard to viral suppression. So this is a group that is in need of significant intervention. And so the sorts of things that one might have to think about, and I was sort of hearing this in the conversations yesterday, is that we have to deal with a lot of stuff in our patients with these biomedical interventions. And things don't happen in an organized sort of way. In fact, they're somewhat unpredictable when things are going to happen. In other words, with release from prison, when are they going to be homeless? Immediately for many. In others, they're couch surfing. Relapse to drug use oftentimes happens within 2 weeks. There's a number of factors. They go back to sort of really very unstable relationships with partners who commit acts of intimate partner violence. I don't know why we call that intimate partner. There's nothing intimate about that. But nonetheless, there is all of these sorts of activities. Individuals often don't get medications, and so their mental illness is unchecked. So there's all of these factors that go into these sort of interventions that may do cartwheels forwards and backwards that we have to think about, but which parts are going to be the most effective? Now, I don't want you to walk away from this, even though it's one of the CDC Debbies, that directly administered therapy is the right way to go for all individuals with drug users. It's been replicated in 4 randomized controlled trials. One recent one in methadone clinics showed that it didn't work, and for individuals who don't have substance use disorders, it is actually not effective and may be harmful. But in this particular study, what I want to talk about is where the rubber hits the road. What are the lessons that you learn, and what you might have thought about when you design the trial that might have made it better. So I'm basically going to sort of tear apart my own trial, if you will, as a means of thinking about what to do with this. So this is a group of patients who have tons and tons of medical and psychiatric comorbidity. 45% met criteria for an Axis 1 psychiatric disorder that was not a substance use disorder. About 60+% or so met criteria for opioid dependence, 90% met criteria for cocaine abuse, and about 30% met criteria for alcohol dependence. So there's a lot of underlying comorbidity. 80% have achieved viral load by the time that they're leaving, and their T cells don't look too bad. What I want to point out, and had we had the funding to do this in a sort of a most strategy, we ended up getting an R21 because we said, what if there is the potential to really take a look at integrating? It's the idea of integrating a treatment for an underlying substance use disorder, that is treating with buprenorphine. This is when it first came out, treating those individuals if they meet criteria for opioid dependence as they go out, which was sort of an unheard of sort of concept back when this trial started. Now, the good part of the trial is that the directly administered therapy worked, but I'm going to sort of make some observations about what it is about directly observed therapy. I don't think it's just the directly observed therapy. I think it's really the monitoring and the social support. So if you can come up with cheaper, more cost-effective ways to provide that, I think that that's important. But let me just say that we also are not good at predicting who's going to do well, because clearly 50% of these people did just fine without us doing anything. And so you don't really need to expend this huge amount of effort. So one of the things that you might want to be able to do is to sort of figure out a priori who needs an intervention that really is costly and very time intensive. And I think it's part of the reason why I have very few hair follicles left. But there's a couple of other lessons that everyone knows. I didn't have hair before this trial was started. There were a couple of really important lessons, I think, that learned. So as you see right at the beginning, just enrolling somebody in a study, they always do better. So if you're going to do, this has important implications for adaptive designs, because you roll them into a study, you're going to get some kind of benefit just from enrolling them in the study. And I'm going to show you the parallel stuff with the treatment as prevention data that shows risk behaviors for with PrEP also works. There's also something incredibly arbitrary about the way we decide when the outcome is. We choose this magical 6-month time period. What does that mean? Why do we do that? We do that because we have 5 years of funding and we've got to get through it, and we say that's the time of maximal viral suppression, but we do this and we keep getting funded, and if we don't say that, we don't get funded. But let me give you an example, and this is just of one patient, but what if we repeated this at different time points for 154 patients? This was a patient who, in the red, was the time period when he was on directly observed therapy and was taking his medications, and you see a couple of laps. But at the time point when we measured the 6-month outcome, he's on therapy and he's achieved the final outcome. Doesn't do so well at the end, and he has a period of not taking the medication in the middle. So people, it's a chronic relapsing disease. But what else is going on that is a time-dependent factor? And this is where the really smart people from the Methodology Center really have to help us think about how to do this a little bit differently. But this guy goes home, goes on an alcohol binge. His wife takes a baseball bat, sends him flying, maybe appropriately, and not that anyone should be beaten. And then he doesn't have a place to live, so he's homeless and unstable. This person was also on psychiatric medication, so he's no longer taking his medications for his underlying mood disorder, disrupting sort of the treatment as well. And then, of course, he has a repeat episode. See, these are chronic, relapsing social and medical and psychiatric comorbidities that intervene at different times, and making it a real challenge as you're thinking about how long and when to do certain kinds of measurements. The other things that we learned during this study, so we're looking at this magical moment of 6 months after being observed on the intervention. And when you do the multivariate analysis, yet lo and behold, it looks magical. Directly observed therapy is effective. It's 3-fold more likely to produce a non-detectable viral load than those who get self-administered therapy. If your viral load was suppressed to maximal viral suppression, that too is independently important. But there were 2 other signals that have been really the nidus for beginning to think about additional components of an intervention that may or may not work. And that is that if you had treatment for an underlying opioid dependence with the buprenorphine as part of that trial, you were doing just as good as directly observed therapy for the most part. And if you had an underlying alcohol use disorder, you were 64% less likely to achieve the primary outcome, that is viral suppression. So what does that do in terms of thinking about this? So let's take a look at the substudy of the 94 patients who met criteria for opioid dependence. And Sandy Springer, who was really doing a lot of really impressive work with this, looked at these individuals, and we looked at what's the acceptability? Well, we had some very interesting things. 3/4 of the people wanted it, but there were all of these sort of structural factors that got in the way, in that if they were going out on parole, their parole officer would violate them if they were on a medication-assisted therapy. So people who would have wanted it didn't get it. So there are structural factors that go into this. And people changed their mind in either direction. So they didn't want anything because they said, I'm clean, why would I want to get addicted to another medication? And other individuals said, I really want that, but when the rubber hit the road, they did not want to be on anything when they got out. But what you can see is that 50 people initiated buprenorphine treatment, so over half. And the outcome data looks just like a clinical trial. 50% are retained on buprenorphine at the end of the 6 months, so we're doing pretty good. So it looks just like that we see in the clinical trial. So as a sort of a proof of concept, the buprenorphine worked for these individuals. But now, when you just look at these 94 patients who have opioid dependence, what you see in the multivariate analysis looking at achieving maximal viral suppression, you once again begin to see these sort of health disparities kind of raising the spectrum of problems, in that women did more poorly than men, African Americans did more poorly than whites. Obviously, if you have your viral load suppressed before you leave, you do better. But now, the impact of directly observed therapy, this expensive intervention, drops out. They probably don't need, if they can stay on the buprenorphine, they don't need someone coming and finding them and administering the medication, because what the directly observed therapy person does is they go out and find them when their life is not organized enough for them to show up and get their own medications. And they provide them social support and assistance with other services. So really what that is that's monitoring. So it's how do you do monitoring for these individuals? Directly observed therapy was just a ruse for what the real issues were in these individuals. So then that raises the spectrum of why do we wait until a person is leaving prison to treat their underlying substance use disorder? We don't do it for diabetes. We treat them all the way through. We don't wait until they leave to treat their HIV. And Timothy Kinlock and their group in Baltimore did a very elegant study, and they basically did a randomized trial of patients who were within jail who either got counseling, they got counseling and a get out of jail free that you could go straight to the methadone clinic, so that's a transfer coupon, or they got initiated on methadone therapy and they got the counseling. And as you can see that at least for 3 of the accepted treatment, these were not HIV infected patients, so I'll move to that in just a second. But in terms of days in treatment, getting methadone before you start initiating the treatment was really good because people relapse almost immediately after release. And in fact, from some of our studies in Malaysia, they often relapse the same day of release. More people entered treatment, but the completion rate is still significantly better at 1 year for those individuals who got methadone, but it's not good. It doesn't look like methadone treatment does in the community. And so what is the question for why that happens? Well, when you go back and you kind of try to dig through all of the papers and try to figure out what it is, these patients were on incredibly low doses of methadone. It's kind of like giving patients AZT monotherapy and not combination therapy. They were not getting a therapeutic dose. And so Jeff Wickersham, as part of our studies in Malaysia, looked at individuals who left the prison at what I would call a therapeutic dose of over 80 milligrams versus less than 80 milligrams. And so dose matters for these individuals, so you need enough time to get them on to effective therapy so that you can keep them retained in care. So that 36% is now increasing up. The overall number ended up being about the same, about 36% overall. But if you stratify based upon the dose of methadone that they had when they left, they do significantly better if their methadone dose is higher. Now, the other part of this population that is challenging is sort of retaining them in care. And this is moving to a jail and not a prison population. But these are data from the SPINS project of national significance looking at linkage to care after release from jail. Over 1,270 patients were recruited into this across 10 sites around the country. And this is longitudinal data, but it gives you some insight in terms of if you wanted to do that randomized controlled trial and which components of the interventions might be effective, how you design that. So I put these in to sort of give you that sort of guidance. Right off the bat, you've got 34% who drop out. If you want to call that early retention, I think the right word is linkage, getting a viral load in T cells within the first 3 months, 19%. But you only have 40% of individuals who are retained in care, and that's part of what is required in order to get your antiretroviral therapy. And then you've got the next step, which is you've got to sort of adhere to that therapy. But when you look at the sort of independent correlates of being sustained in care at the end of 6 months during that very chaotic period, you see once again some of these health disparity issues. Men do better than women once again. Having an HIV provider before incarceration, that is knowing where to go afterwards. What's interesting is that using heroin before incarceration was predictive, and for those of you who know me, typically I would have demanded that every site monitor whether they got methadone or buprenorphine afterwards, but it didn't get measured. So it may have just been a measurement of the fact that these people got linked to effective therapy afterwards, because I was hammering that at the intervention meetings, but we didn't measure it. But even these very brief interventions, a discharge planning within the jail was effective. A disease management session, information and motivation, and some behavioral skills, but very brief, a single session. Getting a needs assessment after release, that means that they had to get sort of at least one visit, so that 38% who didn't show up, or an HIV-related education or some assistance with transportation. So we're beginning to see some of the pieces of the model that are going to be important. And I'm just about to get the gaff in 5 minutes, so I'm going to probably not get through all my slides, but that's okay. Everything that I would have said is going to get said by others today anyway. And then Jamie Meyer did another look at the sort of post-release vulnerability of women. And at every point along the HIV continuum of care, women do more poorly at every single step, suggesting suggesting that there may be additional factors that or components of an intervention that may be important. So we may not be able to distill the intervention just down to a handful of sorts of things. Alexei Zelenov did some other work looking at this issue around transition to housing and really recognizing that there's the chronically homeless, those that were before and afterwards. There's something very adaptive about those folks. They know how to be homeless, they do okay, but when you change your homeless status, we see that a couple of things happen, is that the transition to housing is also, like Seth showed with regard to risk, the issues of food insecurity. Not having that is an important factor in that, and not using alcohol, and the opioids doesn't pan out in this group, but also the transition in the opposite direction, that is having a place to live before going in and becoming homeless. Becoming food insecure was sort of a proximal step to that, using cocaine, and either having an underlying depressive disorder or deterioration in your symptoms. And the housing component contributed on average to about 15% increase in viral load suppression among these individuals. So I think that the questions that we really have to raise for ourselves is that are other treatments for substance use disorders likely to run in parallel with the treatment of HIV and result in sort of optimized treatment outcomes? In other words, can we treat the parallel disorder? We could actually say mental illness, treat that, and then see if the HIV is. All of these things are amenable, but then you start to put together this whole myriad and which components are important and which ones are not. So for instance, with the extended release naltrexone for the alcohol use disorders, will people accept injections, and what are the retention and safety issues in HIV-infected patients on antiretroviral therapy? Similarly, for the treatment of opioid dependence, acceptability of the injections. Also, the concern has been raised on overdose, and we've been looking at that. Those two studies are being led by Sandy Springer in our group. The use of methadone for treatment of opioid dependence with a multifactorial design, with or without a behavioral intervention, HHRP. And then, of course, we're looking at the use of RTAS-2 in Ukraine as part of this. Let me just say a little bit about the retention and what may be important for these kinds of interventions for injectable naltrexone. We see this drop-off after the first month that is quite significant. And then, lo and behold, what happens? You say, this is the example of you get partway through your trial and you say, oops, this isn't working. What we see is that we see this marked drop-off to sort of retention being about 50 or 60%. So we ended up getting some supplemental funding, and we put in a medication reminder, cell phones, reminders. And what you see here is that these cell phone reminders increase by about 10 to 15%, the retention, so you can actually increase that likelihood over that time. I think Seth really sort of covered very nicely the issue around the role of treatment as prevention. Let me just say a couple of quick things about the next step, is that once individuals are linked to care, they have got to get prescribed antiretroviral therapy. And who gets prescribed antiretroviral therapy is not always the patient's decision. Ryan Westergaard did a very elegant study looking at 3 different strata for CD4 cell counts, and nobody would argue that if the CD4 count was less than 200, whether you would initiate therapy, and compare to individuals who had no injection drug use or were abstinent for 3 months. Those individuals who were actively using or even just occasionally injecting, they were significantly less likely to have their physician prescribe them antiretroviral therapy. So it's not all in their hands for why they do that. And should there be interventions targeted at providers, a behavioral intervention for providers with regard to therapy? And as a proof of concept for what may be an intervention for these individuals, in a different study, the Beehive study, looking at the use of integrating buprenorphine into HIV clinical treatment, what you see is that for individuals who are retained on buprenorphine for at least or over 6 months of therapy, there was a threshold. They have to sort of get over that 3 to 6 month sort of period of quote unquote not using drugs or being engaged in care. And as you can see, they begin to achieve considerable equity in getting one prescribed antiretroviral therapy, but also with achieving viral suppression. I'm going to quickly skip to the end of my talk since I've run out of time, because I was going to talk about the issues of how adherence plays a role. But one of the things that I think that we're going to see, whether it's in PrEP or in non-PrEP studies, is that there was just recently let me just go back, there's some recent data that suggests that there's a couple of drugs in 2 different classes that have long-acting injectable formulations, so this whole issue of adherence may be reduced. Some of them last as long as 30 days with very effective levels, or in the case of the other drug, 90 days, and they can be combined into a non-nuke regimen. So if we're thinking about one, prevention, in the same way that we do contraceptive therapy with an injection every 3 months, we may be moving into the point of being able to overcome some of these sort of adherence issues. And NIAID also saw this as an opportunity, this was just released 2 days ago, to really to create these sustained release pharmacotherapies. So there's a whole RFA that is out to do that. But let me just say, in parallel, we already have extended release naltrexone, but in trials and in development are extended release buprenorphine and these implantable naltrexone and buprenorphine that last for up to 6 months of therapy. So this sort of issue around being retained on your substance abuse treatment and your HIV treatment may be able, it won't be the silver bullet, but it's moving in a direction to starting to end up with good outcomes. Let me just end by saying that half of everything we teach you is wrong. Unfortunately, we don't know which half, and hopefully we'll spend the next half of this day trying to disentangle some of that and figuring out optimal ways to do that. Thank you very much.